All right. We are going to go ahead and get started. Good morning, everyone. Thank you for coming and for braving this weather, which I understand is pretty bad or will get even worse. So thank you all for coming. My name is Michael Kugelman. I'm the Senior Program Associate for South Asia with the Wilson Center's Asia program. We soon hope to be joined by some participants at CENTCOM in Tampa, Florida, hence this. Hopefully they'll be able to join later when the technology allows for it. Also wanted to thank the Wilson Center's Maternal Health Initiative for serving as our co-sponsor this morning. Let me take a brief moment to talk about the Wilson Center. As I imagine some of you may not come here all that often. We're the official memorial to President Woodrow Wilson, who's the only U.S. president to have held a PhD. Makes for some nice cocktail party trivia. The Wilson Center is the nation's key nonpartisan policy forum for tackling global issues through independent research and open dialogue to inform actionable ideas for Congress, the administration, and of course the broader policy community in Washington and beyond. It is easy to forget, amid all of the news headlines about terrorist attacks, that Pakistan faces a multitude of human development and natural resource challenges. These range from water and energy shortages to food insecurity to public health problems, including a very serious polio crisis. Over the last few years, polio has resurged globally, and Pakistan is at its epicenter. This year, Pakistan has reported about 70 new cases, which is more than any other country by far. Most of these cases are in remote tribal areas of Pakistan, particularly North Waziristan, where there have not been, as I understand it, there have not been any vaccinations for 2 years. It's important to emphasize, though, that some new cases are also being diagnosed in cities, such as Karachi. And just yesterday, Pakistani media were talking about how the polio virus had been found in sewage samples in Lahore and in Rawalpindi. Now, much of this debate on the polio crisis in Pakistan in recent months has tended to focus on how militants are preventing people from getting vaccinated. And this is certainly true, though this is a crisis that is really about much more than just militancy and how it aggravates the problem. So we are delighted to have with us today Samia Altaf, Dr. Samia Altaf. Samia has truly made the Wilson Center proud. She is a previous Wilson Center Pakistan scholar, and the project that she worked on here culminated in a very well-received book about Pakistan called So Much Aid, So Little Development. Since then, she's continued to be engaged in matters of health policy and international public health assistance in Pakistan. And recently, she's been doing work on polio specifically. So today, she'll be presenting this new research, and she will be providing some new insights on Pakistan's polio crisis and what has driven it over the last decade. You have her bio, so I won't read it line for line. But Samia is a physician, and she's a public health specialist. She served positions at USAID, at Aga Khan University Medical College in Pakistan. She's worked at UNICEF, she's consulted international aid agencies, and also she's served several positions here with the DC government. With that, I will turn the stage over to Samia, who will speak and give her presentation, and then we'll have plenty of time for questions. Thank you.
So thank you very much, Michael. It's an honor and a privilege to be back at the Wilson Center, and I wish to acknowledge the Wilson Center's support in most of my work over the past 6-7 years. True to its tradition, the Wilson Center is continuing to debate with critical policy issues. Very special thanks go to the Asia program, Bob Hathaway. John Sewell is here. I'm very honored that he came. John was very early on, allowed me to be my sounding board in which direction I was going. So I owe enormous thanks to John. And of course, Michael Kugelman, the enormous thanks to Michael for being responsive and putting this together at the last minute. And I thank very much all of you coming here to talk to me because it is really a difficult morning. So as you know, Pakistan's polio program has been in the news for the past many months now, and very interesting quote-unquote stories have been coming out about it. Till recently, Pakistan was one of the 3 countries that was where polio was still endemic. In most of the other countries of the world, polio had been completely eradicated. And the international community felt that it was poised to eradicate it now completely from the world. So the countries were Pakistan, Nigeria, and I think Afghanistan, yeah. But starting from 2004, 2005, when Pakistan, that was the last year that Pakistan had the lowest cases of polio, starting from that time, it just started to unravel, and the program, in a sense, started to unravel. Recently, you see that WHO has slapped, travel restrictions on Pakistan, that anybody traveling out of Pakistan must be able to show certification that they are protected against polio. So it's really a very serious issue now. The popular narrative over the past months, as is the want of popular narrative, looks at the immediate issues that are in front. So of course, there have been these horrific murders of polio vaccinators who've been going out to vaccinate. There's this understanding that people are refusing polio vaccination because of religious injunctions. There is this understanding also that people are refusing polio vaccinations because they associate those vaccines with kind of covert fertility drugs or whatever. I have been involved with Pakistan's health system and been in public health for almost 35 years, and have worked through different regimes and different governments in Pakistan very closely, and has also represented US government in Pakistan. And so I feel, and I will present that to you, that this is really not the whole story. The program and the issues are large enough and complex enough that they cannot be reduced to 1 or 2 sound bites. So so that is basically what I'm going to talk about now. So if you look at coverage rates for Pakistan, over the past 25 years, the vaccination coverage rates have never been better than 50%. In communities where of low socio-economic status, the vaccination rates have been as low as 26 to 25%. And in communities that are of high socio-economic status, they have been up to 66, 68%. So the vaccination coverage rates have never been close to 90%, where a herd immunity is possible. And the other thing is that the religious scholars recently, over the past 2 years, have actually put out almost close to 100 fatwas in support of vaccinations. One of the leading religious scholars, Maulana Samia Altaf, actually came out publicly in support of polio vaccination. So there is that issue also. The issue of polio vaccine affecting the fertility of children is important. It cannot be ignored, and the international community does not ignore it, because in countries like Pakistan, where children are an economic asset, people will preserve their reproductive ability at every cost. So there is that issue, but there is an underlying reason for that issue. And so these issues have been are not some things that came up just now. They've been ricocheting back and forth for past 20 years. And evaluators who have looked at Pakistan's polio program have all agreed that aside from these issues, there are underlying structural problems in the health system itself, in the maternal and child health program in Pakistan, which is the umbrella program under which polio services are also filtered, and specifically with the polio program. And those structural problems have to do with human resource, with infrastructure support, with procurement and storage and transport of vaccinations, with cold chain issues. And those have persisted throughout these 25 years. So if we look at the broad facts about polio, we know the disease, we know how it spreads, we know how to control it. In the past 25 years, every Pakistani government, military or civilian or any other configuration in between, has shown remarkable political will to want to do something about polio. International community over the past 30 years has been extremely generous in terms of funding, in terms of technical assistance, in terms of help with procurement of vaccine. So here we are then. If we know all of this, then why is it that Pakistan is not able to control and eradicate polio? So here is what I found. I spent almost the whole of last year, 2013, traveling extensively within Pakistan and meeting with people and reviewing and talking to people at every level. So federal ministries, ministers, senior bureaucrats, people's moms. I've gone into people's homes, everywhere. And this is what I find. I find that there is a total lack of trust from the citizen side in their government. What they say is that, well, why is it that the government doesn't provide anything else, but it comes actually into our homes to give us this medicine, which we don't even want. We haven't even asked for it. This issue I had also mentioned in my book, that this is, not something new. This issue was also highlighted during the polio eradication camp in Uttar Pradesh, that the people had distrust in the health system. In 2013, November, the government of Pakistan and international agencies put together a huge vaccination campaign, and 35 million children were to be vaccinated. In one of the refugee camps outside of Peshawar, the Jalozai camp, the parents, the camp elders, refused to have 40,000 children in that camp vaccinated because their demand was that they need to have their electricity to the camp to be restored, which had been discontinued by the city authorities, and their food supplies need to be provided. So the system is not providing their essential services, and yet it comes in to give this, which they are not asking for. Trust issue. People also feel that the government is not interested, not only people, but the field level staff feel that the government is not interested in them at all. During that same November campaign, almost all of the government of Pakistan senior and mid-level managers, during those critical implementation field days, they had all gone to Jordan for a WHO-sponsored conference. So trust issue, again, a support issue. The other issue I found was that there is really a real lack of knowledge and information amongst the community members regarding polio and regarding protection against polio. There's research from Aga Khan, which has been conducted in urban areas in Karachi, amongst the Pashtun population, which has a high reservoir of polio, and they found that almost 50% of the parents did not know about the disease. They couldn't connect that, the child gets sick, has fever, blah, 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 and then gets paralysis, and this is because of polio. UNICEF conducted field research in 2012 in 29 high-risk districts in Pakistan, and they found that 40% of the parents who knew about the disease did not know that there was a vaccine and a protection available for the disease. So there is complete, there is the lack of information. The polio vaccination campaigns distribute brochures and make public announcements, but you know that there is enough literature to say that these brochures and announcements are not enough. Even in developed countries, certainly in the United States, where there are anti-vaxxers, you know all about them related to vaccination for children, that even in communities where people can read and write, that these brochures do not help change the behavior and attitude. So in communities where the literacy rates are very low, especially literacy rates amongst women. What are brochures, written brochures, going to do? The other issue I found was that there are huge infrastructure and human resource problems. In that during that November 2013 campaign, the campaign in Mardan and in Nowshera, two cities outside of Peshawar again, couldn't conduct their campaigns because the lady health workers who were part of the vaccinator team had gone on strike. They had gone on strike because they were asking for back pay to be paid for the work that they had already done. And also they were demanding to have their services be regularized. This was a government job. They had been doing government jobs, and they were demanding that. So those two cities' campaigns were stopped. So there are these issues. Then you find that in the fixed centers, so this is what's happening during the campaigns. You find in the fixed centers, there's nothing happening. There's absolutely no activity. You find that the equipment is sitting unused. The trained staff sit idle. There are no appropriate supplies available. Parents who come for vaccinations are actually turned away, and the reports are still being generated to be sent up to the higher level. I will share with you some slides right now. This is a slide from one of the health centers just half an hour outside of Rawalpindi. I'm sure Rashna is aware of that, because this is one of the centers that has been funded and upgraded and supplied equipment from USAID funding. And this is a room. This is equipped as the well baby room, and it has a refrigerator which was meant for storage of vaccines. And you find that this refrigerator has 7-Up and chips in it. Again, this is a room which has another equipment which is lying there covered. This is what is happening in that room. In another room across the hall, there was this young woman. She's 18 years old, and this was her first baby girl, and the baby is 8 months old. She had come for vaccinations. So of course she didn't get any vaccinations, and this lady who you find covered with her head and face is one of the lady health workers, and she's copying down information about this child in her register. That register will become the report for vaccination that will go to the authorities. And this is the center, which very proudly displays USAID funding and involvement. So you find that so this is what is happening in the fixed centers. Since polio services are filtered through these centers, and while we are on the issue of this center and the utilization capacity of the government of Pakistan to use the donor assistance that has been provided, I will also share with you some of the information about the maternal and child health, the maternal health services that are supposed to be filtered through this, supported by equipment through USAID. These are the lady health workers who have been trained through USAID funding, and you can see that they just sit twiddling their thumbs. This is the project, the USAID project, under which this center was refurbished and provided equipment, supplies, chairs, tables, tiles and really done a fantastic job of upgrading this facility. Let me go to this. You notice here that this is what do you see right across against the wall? This is a chair which has laundry drying on it. So, and on the right-hand side, you see this special table, which is an operating table, and you see on the top are the shadowless lights. These are the equipment that have been supplied to filter obstetrical services. And you can see that this room is not used at all. This is another view of that same room. This is that special table and these very special lights, which are shadowless lights. You see this in the same room on the right-hand side. This is the sonogram, and this is the table on which these sonograms are supposed to be used. This is the room, the ward, for the obstetrical patients. There were about 12 beds over there. This is on a regular working day, and these have been refurbished, set up, supplied by donor assistance. These are the ladies who are part of the maternal and maternal health, reproductive health services. They have been trained by the donors to provide reproductive maternal health services, and they just sit there smiling. This is the outside of that clinic. You can see that there is really no demand for service. This is outside of that Well Baby Clinic. You see all these people are staff. This young man who's standing over here is the pharmacist assistant and gopher for everything. When I found him, he was dispensing medicines for tuberculosis. And he showed me his register in which he was making putting together the list to be sent out to the authorities. These are posters and brochures that have been supplied by the donors, giving very detailed instructions about what to do in case of neonatal convulsions. I asked some of the people who were around that if they understood what needs to be done. Some of them did, some didn't, some could read, some could not read. And those who could read said, well, it says you should open an intravenous line. There is no supplies here. There's no intravenous. You should give, Valium injections. Where do we get Valium injections from? So this is what is happening in the fixed centers. So the question is that these reasons for poor service delivery are not new. If you look at the reports over the past 25 years from all evaluators, including the funders themselves, they raise these issues. USAID in its 2013 review had said very clearly, along with, there was a huge donor review of Pakistan's polio program. USAID and Save the Children and, DFID, everybody got together, and these were exactly the things that they also said. In 2012, the World Bank funded and carried out a very detailed review of the polio program, maternal child health program, health services. They said exactly the same things. So my worry is that why is it that these things continue to persist? And why is it that we are not able to fix them? So I'm going to present to you my hypothesis. This is just mine. I'm going to remain consistent with my own methodology of review and my own methodology of analysis. I'm sure there are other analyses and other ideas about why it happens. Mine is that it happens because of program failure. The program failure is because of a flawed program design. The design of the service delivery system is inappropriate and it is out of context with the implementation realities, and the incentives for everybody are aligned against success. All the entities involved, the donors, the Pakistan government, and the contractors, they work and deliver each according to their own institutional objectives. And they are very successful in achieving those objectives. You see, USAID's implementing partner, GSI, has been very successful in doing what they were supposed to do. However, when it all gets combined, it ends up being a failure because there is no service being provided through all of this. In my book, and here I will take an opportunity with your permission to do a very shameless plug of my own book. Thanks to Wilson Center. So much aid, so little development. I actually present a very detailed description and analysis of a similar donor-funded, World Bank-funded program called the Social Action Program, which was an $8 billion program, and it ran for 10 years, which by World Bank's own admission was a failure. And I say that this failure happened exactly because it was a flawed program design, and the incentives were completely skewed. For example, the donor's incentive was to spend the money. They were constrained by spending pressures, so they did not hold the government responsible when it didn't do its part. So they kind of looked away. The contractor's incentive is always to sell their product. For example, they are training institutions, they are research institutions, they are management institutions, they are curriculum development institutions, so they want to sell that product. Pakistan's government incentive is to generate additional funding for its public sector programs, even though it is severely constrained by its own utilization capacity, as you saw. The technical experts lack the contextual knowledge. They bring a cultural blindness Their understanding and their focus is completely defined by their contractual parameters. And they deliver very well on those contractual parameters. And of course, the NGOs focus on a particular piece that they have, and they deliver on that. That was the analysis I presented in this book. I can say that with confidence that this analysis holds true even today. The way the polio eradication initiative of the government of Pakistan was designed, these actors, again, were tied together in such a pathological way that they had to continue to do what each one was doing with the result that we see before us. When we talk of context, let me also bring three different variables in it. One is one which have an impact on polio control and polio eradication. One is water and sanitation. 3 or 4 years ago, Wilson Center had put together a conference on water issues in Pakistan. And I spoke about why Pakistan government, in spite of this technology being available for providing water and dealing with sewage, and why millions of dollars of aid being available, why is it that Pakistan government is not able to provide water to its people? So I won't go into that. That is available on the web. The other important variable is that we need to keep in mind that high endemic areas in Pakistan like Waziristan and Fatah and other areas of the country are actually war zones and have been for the past 10 years. And this is basically what happens in war zones. Poor Fatah and Waziristan's indicators weren't really very spectacular even before the war, and their health service delivery system wasn't much to speak about. But you see, even in places where these things were good, they have also reverted back to becoming repositories of communicable diseases. For example, Syria. Syria was completely communicable disease and polio-free since 1999, but you now find that measles, diphtheria, pertussis, all, including polio, are back in Syria again. The third very important variable is malnutrition in children. Pakistan has almost close to 35–40% of children who are malnourished, and 44% of children who are permanently stunted. I will share with you a slide which I went over very quickly, and I will put it up for a little, this one. If you look at this, very interesting, and this I got from UNICEF, that in 2005, the severely malnourished children were 13%, but in 2014, from the 2014 report, which gives data from 2008 to 2012, you find that severely malnourished number has gone up almost 300%, up to 33, just under 300%. You find that percent of stunted children have gone up from 37 to 44%. Low birth weights have gone up. So there has been deterioration in under 5 child health, which reflects also in UNICEF ranking of Pakistan. Pakistan's ranking in under 5 child health is worse than all its neighbors: Bhutan, Nepal, Bangladesh, India, Sri Lanka. It is worse than Haiti. But in defense of Pakistan, I would say that during these 5 years, there was this horrible flood, which really devastated a whole lot of communities. And so there are some mitigating factors, but still, this reality is very sobering for us. That there is enough research that malnourished children do not seroconvert. Even if you immunize them in time, and even if you give them viable vaccinations, their immune system is too weak to produce antibodies. So, but what is also interesting, I have to share this, that it is very interesting that we are celebrating India's success in terms of being able to eradicate polio. And interestingly and paradoxically, India has actually more malnourished children than Pakistan. 48% of under 5 in India are malnourished. So it would be informative to see how they still have been successful in eradicating polio, and it should really be a guidance for Pakistan to say that it is possible to do that. We can't just, kind of sit back and lament over it. As far as I'm concerned, the argument that Pakistan lacks the resources or the infrastructure to fix these problems doesn't hold at all. Pakistan is a nuclear power. It has shown and it has demonstrated that it can carry men, supplies, vehicles, and everything to the top of a glacier and keep it there for many years. You know, it has had consistent support, very generous and consistent support from the international community. During these 5 years, 2008 to 2012, you know, US government alone invested $115 million only in Pakistan's maternal and child and reproductive health program. $92 million through the Paiman project and another $60 million through the Falah project. And the purpose of those was actually the training and the upgrade of facilities, and that was done. So the question is that why does this continue to happen? This is my submission to you. It happens because there are no consequences for anyone. The average citizens in Pakistan have no voice, and there is no oversight of the government. So, you know, we talk of accountability, but look at the accountability that the government of Pakistan is held to. You know, even in spite of such glaring failures, and I would call this health center that has been refurbished by almost, you know, if you calculate, the $92 million of the Paiman project was supposed to upgrade, what, 18 or 20 hospitals? Rashna is here, at the Tehsil and union, at the Tehsil and district level. And so, you know, if you back of the envelope calculation, about $4 to $5 million worth of investment in upgrading this facility so that maternal and child health services could be filtered out. There was not a single service delivery that happened in the 5 trips that I have made to that center in different seasons, in different times, and at different, in different dresses. So there's no accountability, and now USAID is, I think, as far as I know, is investing another $200 million in Pakistan's maternal and child health program. So if the government is allowed to get away with this, you know, why would they change? This happens in other programs. The government of Pakistan set up its emergency polio program in 2011. You find that that program was very top-heavy in management structure. You know, there were task forces, monitoring cells, senior officers appointed, coordinating meetings, 300 million worth of a program, 250 million paid by the Islamic Development Bank. There was no discussion on the field level infrastructure support that was needed. Vehicles, you know, petrol for the vehicles, TADA for the staff. So the government lays out the plans that are to be funded by the donors, but it very conveniently ignores the things that it is supposed to do. So the next, I know I'm running out of time, so very quickly I will wind up that what do we do? You know, and interestingly enough, now the government has a 2014 polio eradication plan, which is called the Peshawar plan for some reason. If you find that plan, if at all, is you know, much more heavier on these capital outlays and the management structure. There are about 7 committees at each level, so federal, the provincial, the district, the union council, and each committee to oversee another committee, and in the end, you don't know who is responsible. The superintendent police is also there, the deputy commissioner is also there, but who is ultimately responsible, there is no indication of that. So my question is that ultimately, who is responsible? In my view, it is the government of Pakistan. The government needs to make realistic plans which are consistent with its local constraints and have inbuilt self-evident performance markers. For example, one performance marker would be that how does the government's local entity, the district government or the provincial government, how does it mobilize resources for these activities? Government needs to show that it has mobilized those resources. That would be an inbuilt marker which would ensure accountability. The donors also need to hold the government accountable because the donors have a tendency to kind of reward failures. The technical experts like us who come there and advise, we need to bring a larger and a broader skill set, which is basically a contextual skill set. I describe in my book the technical consultant who was a Canadian woman who worked with me on the SAP project. You know, in the beginning, in the first half of her assignment in Pakistan, she kept saying that, you know, I really don't understand the issues. I really don't know what's going on. But, you know, the system pushed her into thinking that she was the expert. She was supposed to do something, so she had to do something. So the other issue is that it is also important that not only what we do, but how we do it is also important. You know, I'd use a clinical analogy because I've been a physician, also a practicing physician for many years, that if somebody has diarrhea and we keep giving them oral medication, we have to understand that it ain't gonna work. We either have to find a different route of administration, intravenous maybe, or we have to find a different kind of treatment. Okay? So, all is not lost. Some things can be done even immediately as of now. One is that, you know, that literature talks about small nudges. For example, even right now, women in the field complain that the vaccination teams and the vaccination campaigns happen during the day when we have other work to do. We have to cook food, we have to go get water. So changing of the time can have some impact. The mothers usually who are responsible for these children are young women, 18, 19, 20 years old. They do not make family decisions. So the vaccinators approach them, bring your child. Maybe the vaccinators need to approach somebody else, the mother-in-law or somebody else. You know that diffusion of information theory talks about, you know, the opinion makers in every community. It is the opinion makers who should be approached. Over the long term, I think that the overall strategy needs to build in trust. There needs to be trust-building activities, which also include political and diplomatic functions. Then there needs to be understanding that the programs must align the incentives in such a fashion that they are aligned towards success. The activities need to be two-pronged. One is that there needs to be a package of services that is offered. You know, there are some people who would say, just feed the kids. Just make sure that they are nourished adequately. But, you know, the package of services should include food for the kids, and it should also include other general medical services so that people understand that, you know, the government is serious about providing services. And the fixed centers, which are, you know, basically the diarrhea over here, the fixed centers need to be made functional. And I think that is where I will stop.
Well, it was reassuring to hear somewhat reassuring to hear the all is not lost conclusion. Those will be very difficult measures to take. Well, thank you, Samia. It was a very sobering, though very helpful presentation, particularly the images. Those are very useful. Let me ask the first question here. I wanted to get your sense as to how urgent do you think the Pakistani government treats this crisis. I was struck not too long ago, a few weeks ago, a BBC reporter asked Pakistan's interior minister how his government planned to get vaccinators into Waziristan to vaccinate thousands of kids that need help. And he essentially said, oh, well, let me get back to you on that in a few days. He didn't even try to give any sort of answer. So you had referred briefly to the fact that the WHO has started imposing regulations in Pakistan, suggesting that the international community is putting Pakistan on notice. Do you think that that will get the officials in Pakistan to see this crisis any more urgently? Or do you think that we just need to wait, however long we need to wait, until these accountability measures are put into place, if they ever are? In other words, what does the government really think about the seriousness of this crisis?
You know, I think that the pressure on the government from the international community, from WHO, when they slapped these travel restrictions, was the first time that the government itself acknowledged that the data is not entirely accurate. Was the first time that the government of Pakistan acknowledged that the negativity related to religion is no more than 0.05%. So there are very tangible outcomes to these kind of pressures from outside. So I think that the more international community leans on the government better they would respond. The issue is that I now think that, of course, I spoke at the Atlantic Center last week, and my co-panelist was Ambassador Lang, who was very knowledgeable and very experienced. And he represents the international communicable disease polio control body. And of course, they are looking at other ways to see how they can hold Pakistan accountable. And they are willing to help with putting together things. So that is wonderful. But if you look at how the government of Pakistan responds, I don't doubt their sincerity at all. I don't doubt that at all. I don't doubt their effort. But if you look at how that is translated into tangible activities, it is very poor. It shows a complete failure of leadership as far as I'm concerned, especially technical leadership. And this is not peculiar to polio. If you look at it, and it is very interesting, if you look at the polio Peshawar plan, it is a wonderful 70-page document. But there is no translation of and of course it's a document for guidance. It shows the government's political intention. That is what it does at that level. But there is no translation of that into actual specific activities, and there is no association of that activities with actual resources being mobilized to do that. Again, if that doesn't happen, then how are these things going to get done? That is not peculiar to polio. Let me also alert you to the government of Punjab's recent 2013 health strategy that the government of Punjab has put together. And it has funding to implement those activities, $100 million from the World Bank and 92 million British pounds from UK, and another close to $30 million or pounds, I forget which currency it is, for the technical assistance to be brought. If you look at that strategy, it is exactly a repeat of what gets done. High-level management things and objectives which are donor-funded. And then the strategy lays out the outcomes, that this will reduce maternal and child death rate, this will improve this. There is no indication at all in terms of how this is going to be done, who is going to do it, how is this going to be implemented through this 18th Amendment, where the provinces have now become much more accountable and responsible. So, the minister's response that I will get back to you on that is entirely appropriate. I just think that the government is not, it's a failure of technical leadership. So I think the technical oversight that needs to be brought to this kind of a thing is just not there. Who are the technical experts who are looking at this government strategy and going back to them and saying, look, this is not going to work? I worked for DC government for many, many years in different capacities, and we used to, and for Medicaid, designing programs for indigent population, we got federal money, we design programs. When we design a program, that design is reviewed, that design is debated by consumer groups, by academic institutions, by internal government organizations. That stays on the street for review, for discussion. It gets changed. We, the Department of Health and the government, have to justify why we are doing what we are doing. How are we going to make sure it gets done? Who is doing that for this 92 million pound program? Who's doing this for this polio program? Who did this for the polio emergency plan of 2011?
All right, let's take your questions. If you could wait for a microphone to arrive before you ask the question, because we're videoing the event, that would be great. And if you could state your name and affiliation. So the first question will be right here.
Thank you. Very interesting presentation. Rashna Raoji, USAID, Washington, Bureau for Global Health. Samia, what you've given is a very good overview of a problem which Pakistan has been facing for the last 30 to 40 years. It's ingrained in the whole system. It's total lack of leadership, and all the infrastructure issues you've raised are on the target. What I'd like to hear from you is, what would you recommend really for us going forward to what do you think should be done? I mean, some of them you've listed, but what it is going to change, because we've been talking about these issues on, and it's just still there. That's one. The second part I have a question is right now we are facing big militancy and the problem in FATA in Waziristan, which is the hub and where the polio virus is harboring. How do we reach out and get them engaged in trying to support this whole important area of eradicating polio and trying to improve the immunization status, and across the board, I would say the whole health sector is struggling, especially in that region with women and the emergency obstacle care and all that stuff. I know I've asked too many things, but I thought it'd be interesting to hear your take, and some points which we could take into consideration. Thank you.
Thank you very much, Rashna, and I'm very glad to see you here. And of course, you're right. I've been talking on and on and on about these things for years. Poor Rashna, long-suffering, she knows that this has been a bee in my bonnet for the past 25 years. So what to do about it? Rashna, you know well, and I presented that over here. I presented that in my book, that the process, and you are aware when we designed this GSI, maternal health support to the government of Pakistan, that there were a huge controversy in terms of how the process of the program design. And those of us on the other side actually failed to get that through. So you know so my fight at that time also was that the process is very important. So that process is laid out. There is email exchange between USAID and I and you and Global Health, in which we talked, people in the mission talked to people in Global Health as to what was to be done. The mission wanted to design it in a particular fashion. So, and I understand that organizations, that is why I say that organizations have internal constraints. And I could understand that there was a constraint about the pipeline getting very big and being emptied out too slow. So, we cannot wait for the government to do this, that, and the other, because we wanted the government to put its two on the table before USAID put its two on the table. But the governments are also smart. They know that if they kind of shake their head and delay a little bit and hem and haw, there will be spending pressures on the donors, and then we'll say, okay, fine, let's go ahead and do that. So the process is what is important. The issue of FATA and Waziristan and getting services into areas which are really very remote, that is really not, and it's very difficult. We can't pretend that it's very easy. It is very, very difficult, no matter how worrisome it is. But because it is so difficult, it needs very serious engagement. It needs very serious thought. There are entities that can go into those areas and still work. There are some NGOs who are going there. The armed forces can go there. Your Pakistani army is very well organized. They are very good at, and also they are very good at helping with these kind of things. I saw how US military, functioned with such meticulous precision to set up health services after the earthquake. It was just spectacular. So there are, and there are these organizations that are willing and available to do the work. So it depends on us, really, which is why I say that we have failed, the technical experts. It depends upon us, the technical experts, to really bring together that level of technical expertise and that level of analysis, really the details, each detail, that the devil is really in the details. So.
Woman in the back, yes, you.
First of all, thank you very much for such an insightful and enlightening presentation. I read some parts of your book and truly appreciate the factors that you revealed leading to the disaster of the innocent people in Pakistan. My name is Farhana Shah, by the way, and I have this experience of working in public sector universities in Islamabad, as well as Peshawar too, and very well familiar with and can relate my experiences with your observations, which are based on facts. Having known that, my question is, okay, what could be the first step to break down the vicious cycle due to this, systemic and responsibility issues? And what would be, or what would it take to turn the vicious cycle into a virtuous cycle?
Should I answer?
Yeah, if you'd like.
Thank you very much, Farhana, and I appreciate very much your asking this question. I think actually you've asked a very good question. The first step is that, in all humbleness, we have to admit that what we are doing is not working. You know, all of you are familiar with your encounter with clinical medicine. You know, I'm a physician. I give you medicine for throat infection. You know, if your fever hasn't gone down, if you haven't stopped vomiting, if you still have pain, I should be the first one to say to you that, look, this medicine that I gave you is not working. I need to do something else. I need to bring more information. I need to bring more analysis. Do I need to do another test? Do I need to change that medicine? So the first thing is we have to admit. This is not something that I'm talking about. This is something that somebody like Jeffrey Sachs has spoken about in his book called End of Poverty, where he talks about making the correct diagnosis. So just as in clinical medicine we make the correct diagnosis, in large public health programs also we need to make a correct diagnosis in terms of what is wrong. Our diagnosis over the past 25 years has been that there is a resource constraint. You know, people are not enough trained, so let's just give more money, let's put in more money, let's train more people, let's do this. You know, we should understand that that's not right. So that is the first thing. The second part of your question was that how can we make it into virtuous? Then that follows, you know, it follows a logical trajectory that we look at our resources, we look at what the problems are. We design indigenous solutions. You know, there should be involvement of community, there'd be involvement of local knowledge. So.
Good morning. My name is Arnold Zeitlin, and I've been interested in Pakistani affairs since I opened the first Associated Press Bureau in Pakistan in 1969.
On Mozang Road?
Pardon?
On Mozang Road? The office on Mozang Road?
No. We were in Rawalpindi at that time.
I see.
But two things. The situation you describe, it seems to me, is basically representative of the way government operations in all sectors operate in Pakistan. So there has to be almost a societal change to make any progress. And two, is there a disconnect between AID and the field work where they must be aware of what's going on, and yet the money still flows?
You know, you are right that in all sectors in Pakistan, I was talking about social services, you know, education, health, sanitation, women's development. Most of the services and programs are filtered through the same governance and administrative mechanism. And if you look at writings that have come out of Pakistan, you know, op-eds, written by people who are economists and public policy experts, you know, are much better at this than I am, speak about governance and administrative issues as being the stumbling block in everything. I can't speak to all of those, but because, you know, those are not my area of expertise, but certainly in health and population welfare, yes. So, you know, but I can assume that this would be, you know, at the back end, all of these things add up and have a cumulative effect, because I can give you this example that, you know, if the education system is failing and the population cohorts that are coming up are not educated enough, I have great deal of difficulty finding vaccinators to train. I have great deal of difficulty finding nurses to train. So it adds up, yes, but I wouldn't be able to speak to the specifics of that. In the issue of disconnect with AID and fieldwork, yes, absolutely. I think, and I'm very perplexed. AID is an absolutely outstanding organization. It has experience, it has smart people, it has done wonderful work. I think AID hasn't been able to make the switch that Pakistan of the past 10 years is not the Pakistan of the last 50 years. It is still not being able to make that switch of changing the model in the way that it does business.
Let me now turn for a moment to our participants at CENTCOM in Tampa and ask if any of you would like to pose a question to Samia.
Hi. Quick question. We just talked about it briefly, but you brought up
looks like we're
the
not
cultural
hearing you.
differences. Oh, can you hear us?
Well,
Hello?
I apologize. We'll try to come back to you a bit later, but unfortunately we're not hearing you right now. Yes, in the back there. Yeah, you.
Mike's on.
Yeah.
Ann Reese, as you and Michael know,
Hi, there you are.
with a long interest in Pakistan, where I have worked several times only with Pakistani organizations with no government connections of any kind. In the mid-'80s, I worked for 3 years in Marrakesh as director of a residential rehabilitation center for boys with paralyzed legs and feet, mostly polio. Morocco at that time was believed to have the second highest rate of paralytic polio on earth, mostly because of the worthless health minister. But a very specific issue was the cold storage problem. And we decided that a perfect anti-vaccination campaign was to vaccinate a bunch of children with bad vaccine, and that village or region or whatever, some of those kids would be paralyzed and people would start saying, oh, don't let them vaccinate you, that causes polio. You've talked, of course, about many probably broader and bigger issues, but I wondered how much that is an issue in Pakistan. Do you have any thoughts about that?
At the local level, I have gone into people's homes, and I have in different communities, in Peshawar, in Punjab, in Sindh. And each community, and Pakistan has very diverse communities actually. It's not really completely homogeneous. Each community has its own internal values and its own system of functioning. And each community has its own transfer of knowledge from one generation to the other. So how they handle these things and what stories they tell to each other, how they justify these kind of things are very, very peculiar. And yes, I can understand that people would have this negative feeling. People have negative feelings about, one young mother said to me that her child got paralyzed because he was her firstborn son and her sister-in-law didn't have any children. So her sister-in-law kind of looked at him, with that evil eye, and so he got paralyzed. So, there are all kinds of things it is the responsibility of the public policy people. It is the responsibility of the government, of the policymakers, of the technical experts to make sure that, we bring knowledge and information to people that makes sense to them. I describe in my book, there is a chapter it was then known as NWFP, actually a vaccination day outside of Mardan, in a small village outside of Mardan. And, and it is really actually a true story, because the women over there were asking this question. They're saying, I'm not going to have since I was there, I was pushing them, come on, get your child back. They said, no, we are not going to do it, because this injection was given to my sister's child in the other village, and the child became sick. He started to have fever, and the baby wouldn't even take the breast. This was such a horrible thing. Yes, because no matter what happens, the babies, 3 months, 4 months, if they are breastfed, they will take the breast. So the baby had stopped eating. So there are all these kind of things. This kind of local information and local knowledge and local mindset needs to be brought into the programs. It needs to be part of the health education information activities. You know, I come back to the diffusion of innovation curve, that it has been proved, you know, over in many fields, that there is a certain tipping point after which, you know, there is what is it now, 2% of the people are in the left tail who are the innovators and the leaders, and then there's another 7% who kind of follow the leaders, and then once there is, I think, 16.5% who change their attitude, then there are early acceptors. You know, there is, we talk about science, we say we have brought science to this. I mean, there is a whole set of social science theories that have not been brought to this, and we need to do that.
Gentleman seated near the wall.
Good morning. My name is Al Ingersoll, and I have spent about 10 years in Haiti and have focused mainly on disability and physical medicine and rehab. And I'm wondering if you can speak about the people with disabilities in Pakistan and how the people in the disabled persons organizations are mobilized to be the voice to hold the government and the other officials more accountable.
Yeah.
Thank you.
You know, disability is a recent awareness of the government of Pakistan and Department of Health. I am not sure. I vaguely remember that maybe there is a special program, disability program. So there is. Rashna is shaking, nodding her. There's exactly. So there has been a special. So it has become again a vertical program like these polio, like immunization program and TB program. So it has recently been awarded that stature. So which means that there will be specific activities carried out under disability. But it is still in its very infant form.
Yeah, you had your hand up. The woman right up front here. Just wait for the mic. It'll be here in a second.
Hello, my name is Mary Theory. My background is in training and development. And I'm wondering, of all of these people that you trained and that you saw in these local areas, were there none of them that had any concern that none of what you had trained them to do, they were being able to do? Did none of them raise any questions about that?
Oh, they are very concerned. Of course they are very concerned. They are very concerned, they are very unhappy, they are very angry. They want to be utilized. You know, you see, if you pick up Pakistani papers once a week or once a month, all of these people, you know, the trained malaria workers or the trained lady health workers or the trained, I think under the Paiman project, Rashna would be able to be better at those numbers. You know, God knows 60,000 or 90,000 lady health workers or midwives or whoever were trained. You go talk to them. These 3 women who I showed you, the 4 women who are standing in front of the labor room, they were those lady health workers. They are very good. They are very competent, but they are the ones who are saying, well, give us jobs, give us our back pay, utilize us. If a midwife is going to deliver a baby, and if she doesn't have, you know, any supplies, what is she going to do? I am a trained obstetrician. You put me somewhere to deliver a baby. If I don't have any supplies, what am I going to do? This woman is bleeding to death. What am I going to do? So the whole package, you know, we talk about systems. We need to keep in mind that in any large system, even if a small piece is not functioning, that system is going to crash. Think of the you know, God, I'm getting Alzheimer's. Think of the weakest link. No, do you know this thing that crashed, that went up in space? Just shuttle. Oh God, thank you, thank you. You know this shuttle that crashed? You remember why it crashed? Because of those 3 tiles on its top. This multi-billion-dollar machine, the system that worked like a clock, just those 3 tiles. You know, if you read the review of that committee that had done that, it is fantastic. That just those. So there you go. You know, if all of those nice things are done, those pieces are polished, but there are some screws that are missing, you know, it ain't gonna work.
Let's go to back to Tampa once again, and I invite you to pose your question, and hopefully this time we'll be able to hear it.
Hi, this is Tampa. Can you hear us now?
Yes, we can.
Hold 1 second. She'll move to the microphone. I guess hers wasn't working.
Hi. Briefly, you addressed the cultural issues that we're missing while dealing with the populace there. I was wondering if you thought a plan for every province, especially in the Pashtun areas, because that seems to be where there is a larger number of polio cases. If there's a way that we can look at it in a strategic sense, to send either religious clerics out with them or things like that to get the populace buy-in, specifically when we have to counter-target militancy's IO with, talking about how it's against haram and other aspects of the polio vaccination.
Yes, absolutely. I think it is quite possible to, and actually that is what should be done, that there should be a local review of the communities and local strategy for each community, which should also include, religious leaders, it should include technical experts, it should include mobilizers. But that cannot be done unless there is commitment from the district government, from the local government, from the tehsil level authorities, that there will be administrative support, there will be resource mobilization from the government to then deliver the service. Religious leaders go in and mobilizers go in and they mobilize the people. And if the service is not available, their credibility falls. If you look at the polio strategy 2014, it goes down literally, it has these, communication committee, it has this management committee, it has this technical committee, it has this health education committee, down to the union council level, which is the smallest administrative unit within the district. Under the 18th Amendment, the responsibility for filtering all the services and responsibility for the services, monitoring them, supporting them, financing them, now rests with the provincial governments. The provincial governments, I don't know, maybe they need to provide that support to the district governments. Whenever I talk about things, people who in the health sector are very fond of making comparisons, and we make comparisons. Somebody was making comparisons with Finland or with Sweden to say, well, the religious leaders and people go into local communities and then they just change things and they just do things. I was reading about, I think Finland or Sweden, I forget which it was, that almost, 2/3 of the funding decisions are made at that level. 2/3 of the funding, 2/3 of the spending is done at that level. So there are concomitant empowering actions that need to be done by the government if the activities and the services are going to be provided at the local level.
As long as it's real brief. We need to wrap up. Well, actually, you do, because we're videotaping. It's coming.
Thank you. I totally agree that, lots of things have to be done. But if you look at Bangladesh, you look at India, you look at Nepal, the regional countries, I think the reason they've been successful is because the commitment came from the highest level and a strong civil society. People, country itself owned the need to improve the health situation of the people, including polio and immunization. I think Pakistan has been in a crisis since the day it was created. Since 1947, politically, it's been in a total crisis from one government to another government, and health has never been a priority. And I think still, until that situation changes, we will continue struggling and continue to be donor dependent, continue to be having ad hoc planning, and that's not the way. And I think, I don't know what the answer is, but something has to change. And I just feel that, this kind of sessions and events does continue to raise the issue and create an awareness, and I'm hoping that something can be done. Thank you.
Did you want to respond? The final word, Samia?
No, I quite agree with Rashna, but I think that is how I started, that there is a commitment at the highest level. So what more commitment can we want? There has always been commitment at the highest level. That commitment, the issue is the translation of that commitment. And in that, we are all equally complicit.
Well, I think it's very important that there be these types of discussions in Washington, discussions on Pakistan in ways that go beyond the security situation and militancy. These are very critical issues that affect so many people. So thank you all for coming. If you could all join me in a final round of applause for Samia Altaf. Thank you very much. Yeah, we're adjourned.
This is the book. That will give you all the answers. To Paris? I would love to if there's a reason.
Okay.
Just a comment, actually.